Hello, good morning to everybody participating. This webinar will go over our APM4 near-term data processes that I mentioned in our past couple of phone conversations, as well as go through measure details of the measures that we run for our APM4 participants and how we got to some of those outputs. In the room, there's Gary Swan, lead on APM4.
Patrick Miles, a QHC RAC unit.
So Jane, Healthier Washington. Missy Martin, Healthier Washington.
And later during the webinar, Shalini Prakash will be joining us to go over the measure specifications. If you have questions on any of these slides or the materials that we're presenting on today, I ask that you please respond with either an email or a question through the webinar, and we'll respond to those as we receive them. You can go to the slide. So this slide here really goes over the flow of data for APM4, but also for APM3 kind of in general. We are using the assignment data or the roster information that's generated by the MCOs that are uploaded into the Provider 1 system to both deliver payment as well as run the performance measures. So these data are sourced from Provider 1. We grab those rosters or those assignment files and multiply them out by your PMPM to get total payments on a monthly basis for the client assigned to you. We are using those same data to run the measures. So we essentially take those monthly rosters and we run it against measure specifications to get performance. The rosters are accurate and reflect all of the enrollments or disenrollments. So if you have some corrections from one month to the next month, those data are accurate and uploaded correctly so that we're getting all of the accurate enrollments and disenrollments that have happened throughout the year. So these would be the final rosters assigned to each participating provider during the performance year. And with those disenrollments, assume that you're saying that I have these 10 clients that I don't think were my clients and they either need to get reassigned to me properly by a different plan or go to be assigned to a different provider. Those changes are reflected in the data that we run for the measures. So those rosters are up to date to the point at which we pull the data. This is a slide. This is a slide that you've seen before. It looks at our how we're comparing our performance year to get any kind of rate changes. So your performance is your own performance. We're comparing against your own baselines. That baseline will be updated and carried forward with you year over year. For the current year, we're comparing 2016 to 2017. That will result in a QIS score that will be calculated in 2018, and we'll figure out what potential rate impacts are in that year. That rate will go into effect in 2019. So going forward in 2018, you're going to be compared to, in 2018, you're going to be compared to 2017. You're going to get your scores calculated in 2019, and your rate will go into effect in 2020. So I mentioned this a couple of times in the past couple of weeks on our weekly calls, bi-weekly calls. Essentially, the top row is where we are at right now. We are looking to purely self-reported data for 2016 and 2017, and we're going to drop all those clients that we cannot either find data on, or we believe are not our clients for these performance tiers. So your QIS scores based off of this reporting, so 2017 compared to 2016, will be impacted in 2019. We are targeting a roundtable discussion to talk about how we're implementing this going forward in the future, but for 2017 and beyond, so think of them kind of in groups. In 2016 and 2017, for your QIS that's impacted in 2019, we're looking for purely self-reported information. But for 2017-18 beyond, that'll impact 2020 rates going forward, we're looking to reset the baseline toward MCO reported rosters, and we'll be hosting a roundtable discussion to work through implementation questions, concerns around how we will work that out. So right now, for what we're looking at is 2016 data, and we're looking purely for your self-reported information. Next year, we're going to be providing you the same kind of information. We're looking to what clients you have as your telling us assigned clients, and we'll drop those clients that you say are either not yours or you don't have any information on, to calculate what your score will be comparing 2017 to 2016 for your rate adjustment in 2019. But additionally, at that same time, we will reset your 2017 baseline to this new agreed upon standard looking towards MCO reported rosters. And the reason that we're doing that is not to skew the data saying, I have complete control over these clients in 2016 and expanding it to a broader set population compared to 2017 that you may not have control over and would adversely impact your performance going forward, negative potentially, to reset your baseline so that we're not getting skewed from one year to the next. So this slide here goes over kind of the scenarios that we've talked about in previous conversations, but there's a couple of different buckets that result in a zero denominator, or a client that doesn't necessarily qualify for that measure. On the first diagram there, numerator and denominator, you can identify that the client qualifies for your denominator based off of your records within your EHR system, and you can determine whether or not they performed for the numerator. So in the first row there, under numerator denominator, the client qualifies for the measure, but there was no performance for that client, so they didn't qualify in the numerator portion of it. In the bottom half, the client qualifies and there was performance. So those will go into your measure rate. Additionally, we're dropping in the next grouping down, we're dropping those clients that don't meet some specific requirements that you've identified in your EHR for your denominator. So the patient does not qualify for the measure based off of what you're seeing in your own EHR data. We're dropping those clients, and that will go into your measure rates. So for those clients in the next couple groupings, for zero numerator, zero denominator, where no data was provided and the patient was either not engaged and or the patient was not in your EHR system, ostensibly that the client you don't believe potentially is your client, we are dropping those clients for the first performance period or the first performance grouping for 2016 compared to 2017. And again, thinking back to the previous slide, we're working to set a standard of assignment towards the MCO rosters, and we'll work on implementation of that, but resetting your 2017 baseline in future years so that we're not skewing your data for dropping those clients. So this is purely for the self-reported measures and for the self-reported measure rates. But additionally, some folks have provided data on the administrative measures. And to make sure that we're consistent across our measure rates, what we're essentially has said that we're taking those clients that you say are your clients and calculating rates for those clients. For those clients that you don't believe are yours on your administrative measure rates, we're willing to accept some data from participants to recalculate what those administrative rates would be. So across all of the clients, for all of the measures, some patients may or may not have been engaged or were inappropriately assigned to you as your client for the 2016 period. Some FQHCs have already provided data on administrative measures, and we're taking that data into consideration. But we're putting it open as an option for all participants. If you haven't looked at your administrative measures, to report additional data back to HCA. And there's two kind of approaches that you could take to that. It's either to reconcile the data that we've already provided and or provide us a list of rosters with clients that you had for 2016, and we can calculate the rates based off of those patients that you say were yours in 2016. And I would underscore for this portion, it is wholly an option of participants. If you are happy with your rates from what HCA has provided, we will accept that as a final rate. But we want to recognize those FQHCs and RHCs that are interested in providing us some additional information on assignment to make sure that we're consistent across the self-reported measures and the administrative measures. So I have a question here. If roster data is sourced from provider one, then how do we go about getting a monthly feed of all of our monthly assignment rosters, including all corrections to enrollments, disenrollments? So currently under finance department from Patrick, they provide updated information on a monthly basis and includes enrollments and disenrollments. I also believe that some providers have set up a bidirectional relationship to get data pushed from them from provider one and or the MCOs on their roster assignments. We are sourcing all the data from the same place, so those rosters in theory should be consistent. If there are questions or issues with those, then we can dig a bit deeper into that. And there's an additional question. Yes, provider one is the single source of member assignments that we're using for our calculations. So for these administrative measures, again, this is an option. And if you're interested in providing us some additional information on those as clients that were assigned to you in 2016, we can rerun your rates for the administrative measures. Or if you want to go through and reconcile the data based off of what we provided, we're happy to take any additional information that you're willing to provide. But we do need to know if you are going to do that, let us know so that we can get to final rates for everybody. And again, this will be, as we're kind of chunking this off in 2016, 2017, this will be an additional option in 2017. So here I'm going to hand it over to Shalini to go through how we generated the measures. She's going to talk about sourcing of the data, some of the common parameters around how we generated the data, and then talk through some of the more detailed specifications on the measures. Shalini, are you on the line?
Yeah, hi, Gary, can you hear me?
Yes.
Hi, my name is Shalini Prakash, and I work with Gary Swan at the Healthcare Authority within the analytics team that supports some of these initiatives. So I just want to give you a quick overview of the kind of restrictions and filters that we apply and how the measures are calculated. This slide shows some of more global conditions that are applied before we get to measuring the individuals for quality measures. So the under the APM4, the quality measures and the people that are identified to qualify for the quality measures are restricted to the managed Medicaid participants only. So the fee-for-service participants are excluded from the measurement, and this constitutes over 80% of all Medicaid enrollees. So the meaning to say that over 80% of the Medicaid enrollees are in fact managed care, and a small proportion are left out globally. Furthermore, we are depending on the assignments of the Medicaid enrollees, the managed Medicaid enrollees, as reported by the MCOs and confirmed by HCA. So there's a process that takes place where the Healthcare Authority receives enrollment files from the MCOs about individuals' monthly enrollment, and the provider or the FQHC that's assigned, that they are assigned to every month. So we use this as, in fact, our source of truth, if you will. And this is cross-checked by HCA and submitted back. So there's some kind of reconciliation or confirmation happening at that level between the MCOs and the managed care entities. So we use these monthly rosters to identify patients that are, or enrollees, Medicaid enrollees that have been assigned continuously to an FQHC entity. So, and we consider 11 out of 12 months that is part of the measurement year for this continuous assignment criteria. So those that are not, that have switched between FQHCs, that have been only partially assigned to FQHCs are therefore excluded from this criteria. So overall, over 60% of managed Medicaid enrollees assigned to FQHCs happen to meet this criteria of continuous assignment. Furthermore, it's the continuous Medicaid enrollment or Medicaid eligibility criteria is applied. So in this case, those that are eligible for benefits, Medicaid benefits that consist of complete medical coverage and not partial medical coverage are part of this group as well. So therefore, since those that are eligible for dual coverage, so Medicaid and Medicare enrollment, those that are eligible for both the services are excluded from our measurement. And further, another group that is excluded from measurement is also those that are eligible for third-party liability. So you could consider enrollees that have other entities paying for their medical coverage that are comparable to Medicaid benefits, medical benefits are excluded. One example would be those that are possibly on TRICARE. They receive medical benefits as part of TRICARE. Benefits from TRICARE would be excluded from our measurement as well. And then we apply the specifications as appropriate for the 7 measures that are part of this measure. So, for example, for some where the measure is completely based on administrative criteria, for example, the medication management of depression, the entire specification of this quality measure is based on claims. So an enrollee's medical history as derived from the medical claims and the claim history derived from pharmacy claims to actually compute the measure is based entirely on administrative claims. So after we've taken care of all the exclusions based on assignment, their Medicaid enrollment status through that measurement year, we get down to the individuals that qualify and look at their administrative claims to compute this particular measure. For those measures that are not entirely based on administrative claims, for example, those that are the 2 measures that are under the comprehensive diabetes care, we do our best to isolate the participants that would qualify based on all the global criteria as I described. And in addition, we also identify the individuals based on their claim history of for use of either a diabetes medication that is specified under the HEDIS specs, or the ICD codes, presence of an ICD code that is specified by the HEDIS specification. So that is the next step of that process to apply the actual measure specification. Next slide, please. So the first one I just wanted to run through is the 2 measures that are part of the comprehensive diabetes care. And this one is the blood pressure under control and the poor control of hemoglobin A1C. So for these 2 measures, which are part of the comprehensive diabetes care, we are dependent on and provide the FQHC entities being able to isolate being able to look at the EHR, query the EHR, and identify those that qualify for the numerator and the denominator. These measures, these 2 measures are the ones where we are able to provide some, based on the criteria, I described the global criteria, and also narrowing it down to those with a diagnosis of diabetes or use of diabetes drugs in the measure year or the prior year. We're able to identify a narrowed down group of people that may be considered for denominator and the numerator, but it is the FQHC entities that are making the determination of who qualifies for the denominator and the numerator from that broader given by NCQA. Next slide, please. This measure is again the controlling high blood pressure, and this again falls under the non-admin only, non-administrative claim-based measure. And in this case, it is focused on those with a diagnosis of hypertension. The HEDIS specification goes down to depends on the confirmation based on the medical record of presence of hypertension in that population for the person to qualify for a denominator. So this is, again, a further, it narrows down your pool even further, that we are to look for or you are to look for based on that cohort or provisional cohort, we're able to narrow down who has on the record in their chart diagnosed hypertension in the first 6 months of the measurement year. I believe this is to ensure that it is not a person who's diagnosed later in the measurement year where there is not adequate time to be able to provide care for that condition. So therefore, since the measure specifies that they be diagnosed within the first 6 months of the measurement year or prior with a hypertension, this provides adequate time for the measure to actually be computed as it involves ongoing care of the patient. For the numerator again here, we are the specifications look for the most recent value where both their systolic and the diastolic pressure is under control and under the specified values. Thank you. Measure specification is around the childhood immunization status, combo 10 measure. And again, this particular measure, we are unable to compute it solely based on administrative claims, but this relies on the information on the electronic chart for the children who qualify for this measure, who has met the adequate criteria of receiving all the 10 immunizations within their second year as specified by the specification. So what we are giving you is really all the children who would qualify under the measure based on age and their continuous enrollment, etc., with Medicaid to be able to qualify for the denominator. And the electronic health records or the chart reviews is what provides the evidence of them having received adequate immunizations to qualify for the numerator and be considered having achieved all the 10 immunizations. Next slide, please. This particular measure, the Welsh Pal Visit, the third, between the third, fourth, fifth, and sixth years of life, is one of the administrative measures where we have the ability to be able to look at the HEDIS specified HCPCS codes and the CPT codes to identify the children who meet the qualifications for the numerator. And therefore, this is one of the measures that we are able to report to you based on the global criteria, and further the measure criteria as specified by the HEDIS. So we have the ability to look at the claims to identify individuals who qualify for the numerator. So in this case, there have been some questions asked as how they compare to other reported entities' measure rates. And there is one caveat, though, that has to be spec'd out, that although HEDIS specifies that we need to qualify this measure only with the visits that are to a PCP, the healthcare authority is unable to make that designation for a qualified visit to a PCP. Therefore, that criteria is not part of the filter. So it essentially considers all measures, all visits that are paid and accepted by the healthcare authority, and there is no qualifier here to be with a primary care provider. And unfortunately, HEDIS does not specify the taxonomies, etc., to be used specifically, and also due to the fact that our data does not allow us to drill down to the taxonomy exactly that is specified in each claim, we are unable to use, unable to impose that filtering criteria. So essentially, it is a loosened up version of the HEDIS specification. And another point to clarify here is also that when an MCO is able to report on this measure, they have the ability to incorporate other sources as well beyond the administrative claims. And unfortunately, we are not able to do that. So the numerator criteria has to be met solely by the visits that are captured by administrative claims in this measure. So in some regards, it is it's a little bit more less stringent. It is less stringent with definition of PCP, but in some regards, it is also narrow because we are unable to incorporate non-administrative claim data in capturing this measure.
Shalini, there's a question on dual coverage. Medicare and Medicaid are excluded from the enrollment and measures, correct?
That's correct. Dual enrollment, and furthermore, also some of the benefit categories, Medicaid beneficiaries that do not have comprehensive medical benefits are also excluded.
Great, thank you.
Thank you. The next slide, please. This particular measure, antidepressant medication management, which I used as an example of completely administrative claims only measure, is another one which lends itself entirely to the claims data. So after applying our global exclusions, we are able to apply the HEDIS specifications as is and use the pharmacy and the medical claims to compute this particular measure, both for the acute phase and the continuation phase. And this is totally dependent on the behavior of the script filling behavior of the individual. So when they fill a script for the antidepressant medications that we are monitoring and for how many days, those that data is what is used to compute this measure. So it's obviously beyond kind of outside the care after the fact that the prescriber has prescribed this medication, which is chronic in nature, and it is dependent more on the behavior of the individual on when they go to the pharmacy and fill up their prescription over that time period that is specified in the HEDIS measure. Next slide, please. And finally, we have medication management of people with asthma. This is again one of the administrative only measures where we are able to capture all the individuals that are asthmatic, all the children that are asthmatic, and who fill the controller medications appropriately and capture the information solely based on their pharmacy behavior, the pharmacy script filling behavior, and also their condition. So the criteria that allow them to be considered asthmatic based on the claim data. So another one point of clarification is that the HEDIS measure itself it looks for all the individuals between 5 to 65 years, but for the purposes of APM4 quality measure calculation, we are just looking at children. And as of now, we are reporting on a measure on 2 different age bands, 5 to 11 years and 12 to 18 years for the 75% adherence component of the HEDIS measure.
And additionally, Shalini, we are looking at potentially small numbers across some providers for these 2 different bands. And I think that we're going to be combining these bands into a single band of 5 through 18, just so that we get sample size up a bit on these measures to make sure that we're able to report it and count it in for APM4 performance.
That's right. So we have received very positive feedback around the advantages of being able to just combine these 2 age bands and in the future you'll see the reporting or the both for the cohort and the measure score being rolled up for the entire 5 to 18-year age band for this particular measure, instead of it being split up into 2 different age bands and having 2 different rates, measure rates.
Yeah. Great.
So Shalini, there is one follow-up question. So just for clarification, do patients need to meet the clinical criterion for the full 11 of the 12 months to be included in the denominator?
So 11 out of the 12 months, we would, what I refer to as more global qualifying criteria for this particular payment model is that of being continuously assigned by the MCOs to the particular FQHC entity, to the same FQHC entity. And this is in addition to all the qualifying criteria by the measure steward, which includes actually being eligible for Medicaid 11 out of the 12 months, which is on top, which is also a criteria that leads us to this particular narrowed down cohort of people that are being measured. So the continuous assignment is in addition to whatever NCQA has specified under that measure of being continually eligible for the benefits itself. Does that help?
Yes, thank you, Shalini. So unless there's additional questions at this point, there was one more.
Will all SQHCs be required to report in 2018?
Yes, our SQHCs will be required to report at a minimum on the self-reported measures. And again, it'll be an option for our SQHCs to review the administrative measures essentially and tell us who you are accountable for in 2017. It's also important to note towards the top of the presentation that during 2017 we will additionally be doing that calculation, but the data that we're providing you will be essentially resetting your baseline going forward in the future. So one portion you're going to be reporting out to us to get us your scores for rate calculation in 2019, so comparing 2016 and 2017, and then resetting your baseline for 2017 forward. And it'll be the same. It'll be the same data that we'll be looking at to do both those activities. Well, unless there's any other questions, we'll give you a few moments to chime in. This will be recorded, or it has been recorded, and we'll post it hopefully in the next couple of days for your review at a later date.
So we got 2 more questions in. If there are updates we want to make to our 2016 QIS submission based on the results of this presentation, how should we go about making those updates?
Please reach out to me and let me know. I can work with you directly on if you need to review some of the data that we've sent you, or you need some additional data or additional time. Just reach out to me and I can work with you.
We have another question that's not a quality question, but do you know if we have any rulings on the change in scope process, specifically if we will be able to do segregated rates?
I don't think we have any answers to that yet. We have a convening scheduled for the end of this month to discuss some of those issues and get at least a briefing on the change in scope. It's our hope that in the coming months that we'll be able to resolve that issue. Great. Well, thank you for your time today. This will be posted in a couple of days for your review.